I mean, I can't tell you how many hundreds of places I've been over my career that I've seen, well, this is how we've always done it. And it goes back to what Maureen just mentioned, is that they didn't go back and re-educate themselves on the most current evidence or the most current guidelines. And this is why I think it's so important that our colleagues that are interfacing with the operating room understand and read the guidelines from ARN.
Clock in, scrub up, and join us behind the red line, where infection stops and information starts. You're listening to a special combined season of First Case and Transmission Control podcasts, bringing perioperative practice and infection prevention together to tackle one of healthcare's most persistent challenges, surgical site infections. Each episode will connect you with frontline staff, perioperative leaders, infection preventionists, and healthcare innovators sharing real-world strategies, stories, and solutions that are changing the way patients receive surgical care. From the back table to the boardroom, from wheels in to wheels out, and from surveillance data to safer practice, we're breaking down silos and strengthening the systems that protect surgical patients. Welcome to Silo-Free Surgery.
Hello and welcome to the season finale of a special combined podcast of First Case and Transmission Control. It's all about reducing surgical site infections and breaking down silos between the OR and infection prevention. Today, we're going to be joined by Maureen Spencer and Peter Graves to talk about everything we could and should be looking at before, during, and after a patient has surgery. We'll be right back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome back to another episode of a special co-branded season of the Transmission Control and First Case podcast. My name is Garrett Hollembeak, and I'm joined today by our co-host, Lindsey Joyce. Lindsey, how are you?
I'm doing well, Garrett. Good morning.
Good morning. Good morning. And as we close out this season, this is kind of our season finale, and we just got done with 4th of July and, big fireworks shows and big finales. So this is a really good and hopefully not explosive, but definitely entertaining and educational way to end the season is with our two guests today. So we have Maureen Spencer and Peter Graves today to talk about looking beyond the kind of standard checklist bundle to really practices that help reduce surgical site infection. So Maureen and Peter, welcome.
Thank you, Garrett.
Thank you. Good to be with you.
Yeah, and we're happy to have you guys. So for the folks in the audience that don't know you, and this is cool especially because, sometimes OR and IEP, we don't all have the same heroes that we see on LinkedIn or people making changes in the industry, but you guys are very visible out there in both fields. But for those that don't know you, and Peter, we'll start with you. Tell us about yourself and your career and experience.
Sure. Well, thank you. Well, I live in the Dallas area, and so I've been a perioperative nurse for a very long time, since about early 1990s. And so I'm starting to get the hang of it a little bit. And so for me, I think one of the things that, I've moved away from the bedside a few years ago, and I have my own independent perioperative infection control practice, and I partner with Maureen. And so really what we've really tried to do is focus on infection control from a partnership. But my background, not only am I, from staff nurse, educator, manager, director, I sat on the ARN board of directors for a couple of years, and I both chaired and was a member of the Recommended Practices Committee for 7 years and wrote the original version of the Transmissible Infections Guidelines. So I kind of get the whole process around infection control in the operating room.
And Maureen, how about you?
Yeah, so I'm living in south of Boston with my new husband. I got married last fall, and I have four children,
Congratulations.
one grandkid, and I've been doing infection control since I was 20. It's the only thing I've done. Right out of nursing school, I started infection prevention in the early 70s, so I've gone through everything, all the challenges that we've had over all these years. Most of my career was up in Boston area where, community hospital, VA hospital. I was the director at Mass General for like 11 years and New England Baptist Hospital, orthopedics. And then I was a corporate director at Universal Health Services. We had 25 hospitals at that point, but they were in 7 states. So I basically lived at Logan Airport every Monday and came back every Friday. But right now, Peter and I, we set up a company called Surgical Infection Consultants, I think maybe last year. And as he said about LinkedIn, we saw that as an opportunity to educate and maybe try to demystify the OR, make it a little easier with these real great infographics we're doing for IPs that don't go in the OR or maybe don't have the clinical background like a nurse would have, and just start to just educate. And that's what we've been doing in our late.
I love it. And that demystifying process. And that's kind of been the theme of this whole season, is breaking down those silos and barriers between infection prevention and the operating room. And that's where we want to start this conversation off. Is for those listening, we're going to walk this conversation the same route that the patient goes. So we'll talk about, our pre-op considerations, what we're looking at intra-op, and then even some of the documentation stuff post-op with SSI surveillance. So Peter and Maureen, when a facility calls you guys in because of surgical site infection concerns, where are you starting with that? It's such a big piece of the puzzle. Where do you begin?
So I'll jump on first. I think one of the things I really do is I rarely start by looking for a single failure. I mean, I think one of the things that we oftentimes see is that it's typically never, SSI is typically never just one issue. It's a kind of a plethora of issues. So really what I try to do is I try to begin by understanding the perioperative system, that kind of the ecosystem, for a better term. Understand all of that information. Sure, I mean, Maureen and I, when we go in, we look at surveillance data. We have to look at that. We have to understand what it is. But then I really want to spend time in the operating room, and I want to observe multiple procedures. I want to talk to the frontline staff. I want to compare what their policies are to what they're actually practicing. And then my focus is not to catch people doing things wrong. I really want to focus on what their actual practice is. Because I think oftentimes what we do is that they automatically assume that we're in there looking for trouble, and we're really looking for a process.
That's super important. And Lindsey, I feel like in some of our other episodes this season, that same point has been hit on, that when infection prevention is coming in, there's a natural hesitation to say, oh, I'm going to get in trouble today. And we've got to dispel that. And really, Peter, I love what you said, that we're not looking at people issues, we're looking at process breakdowns.
I think one of the things we oftentimes see, and Maureen, you and I have seen this multiple times, is that it's typically, the policy is written kind of like nirvana, but it's not achievable because of all the different issues and, roundabouts and shortcuts and other challenges, because it's the policies are written in a room, not in reality.
There's so many there's policies that I don't even know about, like at my facility, that I'm sure it exists because, we're so focused on correct surgical site markings or timeouts or consents that we don't think about policy for cleaning or policy for, shaving or, other. I think that's where IP could come in, that, again, OR nurses, Peter, you'll verify this. We're very territorial. We don't like people coming into our area. And if we see someone who's coming in from the outside, like you said, we just assume we're in trouble. We've done something wrong. Somebody's there to critique us or, tell us where our practice is.
You're hitting on a really important topic here, because I think the one thing that Maureen and I have done and really kind of exemplify is the ability to partner together. I kind of kiddingly call ourselves unicorns, because nobody else is doing what Maureen and I are doing, is demonstrating, kind of living that partnership between infection prevention and the perioperative leadership. Because it needs to be a partnership. It's not, we need to be allies, not shooting at each other. Because honestly, like you mentioned, in the operating room, we don't need another OR nurse coming in to tell us something. We need partners to help us observe what's going on. And that's why I think it's really important to have the IPs in the operating room alongside the OR.
And we've mentioned a few times in other episodes already this season, and I'll say that don't see it at my hospital. I'm not sure I've seen infection prevention come down except maybe once or twice a year. And that's just to either because we have a problem or something going on. But I can tell you that we don't have that partnership. And I'm starting to really, I knew we needed it before, but it's really, the season has shown we have to have that. And we need to figure out how to implement that with more and more ORs. So I'm glad that you guys are out there doing that. I'm curious, when you go into these ORs or these facilities or wherever you guys, how are the staff receiving of you guys or receptive to you and your, suggestions or your observations?
One of the things Peter and I do is we go the night before and just walk through the hospital and just kind of get a sense of the lobby, the bathrooms, people we're seeing and so forth, what kind of security they have. We just kind of get that sense. And, then we want to look at their policies. A lot of times they can send them to us ahead of time, not the data, but, we'll look at their line listing we asked for. But I think the two of us, with the years experience we had and how many years you get pushed around with this kind of work, non-judgmental, compassionate awareness is the attitude a consultant should have. We're hired. We've been asked to come in because you have a problem. It may be different than when Joint Commission shows up or CMS comes up because they're trying to, we caught you, kind of a thing. And at UHS, when I was the corporate director, I would often say, hey, I get the same paycheck as you. We're here from the corporate office, the 7 of us. It was a team, quality team that would go out and devour the place. We were really thorough. And then I would take pictures so corporate could see what your hospitals look like. And then who says that that's an issue on the slide? That's what Peter and I do with these surveys that we do. Rather than big written report with timelines and all that, we're just consultants coming in doing a prevalence survey, slice of life, that day, that week, 2 full days in the OR and SPD. It's all we focus on. And this is what we saw from the lenses we have from an OR manager, leader, person, and an IP with a lot of years experience. And the report is a PowerPoint, and in it, the PowerPoint are the links to who said that was a problem. So whether it's OSHA or ARN or FDA then they have it, and then we send them a lot of documents ahead of time. We even have an SSI checklist that we send to them that they can either do a tracer on several patients and go through the various normothermia and are they getting glucose control, or do they have the MRSA screening, antibiotic prophylaxis, and so forth. Then it has a section that looks at the environmental issues. And we use the ARN guidelines primarily for our documents that are driving our surveys, and we're just trying to get IPs to join ARN. You can join and not be a nurse. You can join and not be an OR nurse, and then get their hospital, or if they want to pay the $600+ Peter and I share a subscription to the e-guidelines. You need the guidelines. It's just amazing how many emails I get from IPs asking me questions that are in the guidelines, and they don't have access to the guidelines. So I often say, just first check with your OR director and see if they've got access to the guidelines. And these are the guidelines I want you to get your hands on. And this is where you're going to find things about instrument packaging or sterile technique. The other day I got one about sterile trays. Where am I going to find information about sterile trays? This is from an IP up in Boston. Go through the whole thing about but I'm like, join ARN so you can get
I loved it. I love hearing that because
it's a great organization. Peter and I work very closely with them, and it's always interesting. We always kind of chuckle that we'll put in abstracts or lectures into ARN, and every single year we get accepted and we lecture, but not APIC. We never get. I don't know why there's not as much interest in SSI prevention. It seems to us, and not just us, even others who have tried to submit. I just wish they would have a module or even a pre-con would be wonderful on SSIs. And let's take them on a journey through the OR. We did this for AORN. I did it with Sue Barnes, who used to be the head of Kaiser. We did with 12 of them across the country, full day workshops for IPs and OR leaders. But it was back in 2017. And we need to repeat that because so much has changed and been updated. Yeah, I think people respond to us very well because of our attitude. We're not control freaks. We're not infection control people. We're infection prevention. And that has just a different emotional slant to it. I think still I see a lot of the control part of it, or like a mother who's upset that her kids didn't do what she wanted them to do. They wash their hands and clean up after themselves. Yeah, I think that's why we work, as he said, we're like these unicorns, but
yeah, that's hugely important. And the emotional slant, that's a good way to phrase it, because when you come in with certain phrasing and the background information is really important. So I'm curious, because I think the trend is for IPs to audit to the policy or observe to the policy with the assumption that the policy is perfect. And no policy that I've ever written is perfect. And we kind of treat them like these sacred cows that are like, well, the policy absolutely must be correct. So I'm curious from your guys' experience, how often is the process actually better than the policy, where maybe the weakness is in the policy piece?
Yeah, I do. Yeah, I find the policies are not updated. They do these reviews every year. I remember going through that at the Infection Prevention Committee, and but they don't update the references, which mean they didn't read the most updated information that goes into that policy and double check it. Data drives your program. Also, looking at surveillance data and seeing where you need to tweak things or make some changes. But go ahead, Pete.
I was going to say, I mentioned earlier on the podcast was that, policy really is ideal practice. And oftentimes policies are not pressure tested. I use the term pressure testing because in reality, when things go south, and they will go south at some point, that's where policies fail, and then clinical practice picks that piece up. And so there's sometimes that gap, and that's what Maureen and I are really trying to ascertain. Because, policies are great on paper, but we need to observe what is going on. Because there's always a gap between policy and actual practice. And that's where, having my colleague looking at it from a completely different lens than I do. Because I as an OR person, it's easy to develop that scotoma, that blind spot. It's right in front of you every single day. But having a colleague that is observant, to be able to say, oh, Pete, did you notice that that's right in front of you? And you don't see it because we've kind of like, you've heard the term normalization of deviance, all right? Where we have a bad practice, or I'll use the air quotes, we've always done it this way. I mean, I can't tell you how many hundreds of places I've been over my career that I've seen, well, this is how we've always done it. And it goes back to what Maureen just mentioned, is that they didn't go back and re-educate themselves on the most current evidence or the most current guidelines. And this is why I think it's so important that our colleagues that are interfacing with the operating room understand and read the guidelines from ARN, because I'll use that as the term, the sole source of truth for the operating room practice. Now, some people will argue with me, and I accept that. But we have to have somewhere that's going to be the benchmark for where we're going to work from.
So I do have a question when it comes to like the data for any of our IPs or OR leaders. How far back is what's considered like most recent? Like 5 years, 10 years? What do you guys usually look at or suggest data wise for leaders if they're going to go back and look at policies to keep them up to date?
The last few that we've done, we were asked to come in because they were having problems with SSIs in a particular service. It happened to be spine service, interestingly enough. And so I'd want to look back to at least 2 years, and just see retrospectively through the infection control committee. So I like to look through 2 years of the committee work to see when did the problem start and trending, and then when did it start to get talked about, and then what were some of the measures that they did do. And then we will look at the line listing. One of them, we picked up on the fact that they were using bacitracin, slathering bacitracin ointment all over the spines. Now, I know working in an orthopedic hospital and doing a post-op standardization dressing program, which was probably one of my most challenging, to try to corral in those caps, get the surgeons to agree to maybe some standardized dressing protocols. And we took pictures. We would go up with our clinical educator, got the patient's permission for education, took the pictures, and I'd find feces on the back of these spine fusions. They can't wipe themselves. They have trouble getting up in and out of bed, a lot of sweat, a lot of dehiscence. If they're using sutures or staples, they're not using something like an incisional adhesive. So here you've got them putting bacitracin, which has, I don't know what its half-life is. I think it's only a couple of hours of action. And then after that, it says this gunk in a dark, moist area like an incubator in the laboratory. And the organisms multiply every 20 minutes. So they just have a heyday in that kind of a moist environment. It's better to keep it dry, than to provide a serum or blood. They love that. We have blood agar plates in the lab. That's what we feed them. So, just by honing in on that. And the other thing that for the last few that we've done is in both the last two situations, the IP director did not tour with us. And we found that just strange that they would hire us. And we don't really, we're not gouging people. Believe me, we're just really trying to just help this problem. And so we keep our fees pretty low and we get into these areas. And if that was me, I'd be like, I want to actually see what the consultants with my own eyes are finding. And in one situation, she didn't even know where the OR was. And she was had a medical background from another country and, was here operating as an IP. And we were like, none of the other IPs even wanted to go to us. They were so intimidated. You could see that. So they gave us an OR nurse that went with us to tour. So those are the things that I think, we're seeing it authentically. We're actually out there looking at these procedures, seeing what's going on. And I don't think there's enough of that, of these people that are in certain organizations writing practice guidelines that don't do that. If they did, they wouldn't write some of the things that they write and recommendations that they put out. It has to be authentic. And the only way you get this authenticity is by going out and observing and watching. Be that silent person. They often don't know what we're looking at. We've got it up here in our head. We're not with a checklist checking everything off. We're just kind of going along, and the pictures really help, to be able to capture that moment. Otherwise, you go back on, oh, what was it that we saw up in the anesthesia workroom or, over there and, with the perfusionist and the cardiac cases. And there's just a lot of things we're looking at in all the different specialties. What I used to do at UHS, we were using Joint Commission tracers methodology, which I think is great. A great way to start is these tracers templates. And so I took them and personalized them to the UHS hospitals. And they were charged with once a month going to the 13 areas and filling these tracers out. At first, I got such pushback. We don't have the time. I'm like, you can do 2 or 3 departments a week. Believe me, you can fit in 2 or 3 departments a week. And you're going to fill this out. They're going to see you. You're going to be visible. You're going to collect the data for continued readiness. And then I, at a corporate level, taking the 25 hospitals to see what my priorities are, which was endoscopy during that particular year. We still had a lot of challenges with endoscopic processing by those forms coming back. So that way they're out there It's part of something they've been told they're going to do this through the Quality and Infection Prevention Committee. Expect your IPs are going to be in your department, and you're just looking at practice as part of the quality continued readiness, getting us ready for surveys, and it worked. I mean, after a couple of months, they're like, this was the best thing you ever did, because now they know who I am. They understand what I'm looking for, and they're almost, a lot of times you go in there like, we already did it. We're all ready for you. We straightened out that problem that you identified. So that's an easy way. I mean, you don't have to use Joint Commission resources, but I liked it because it was all computerized into the system, and then I would get a report. But you can just use create templates. ARN's got great templates. I mean, they've got great survey forms and PowerPoint presentations and videos. A lot of the IPs need to learn what the surgery looks like. Just go into YouTube at home, because we can't use it at work, but they have it. ARN has that on their portal. You can watch videos if you don't know what a total hip looks like or a total knee. So,
I think the other thing I was going to piggyback on is, and Lindsey, you mentioned, how far back do we go back for some of the references? Having written, the guidelines many years ago, we try to go back at least 5 years. But there are some sentinel papers that are out there. It's kind of, I call it settled science. It's like gravity. What goes up comes down, right? So, I mean, no offense, do we need another study in the last 5 years on double gloving? We know it works. All right. We know alcohol-based antiseptics work. Do we need, we know that normothermia is effective. We understand that antimicrobial sutures is the most studied product used for reducing surgical site infections. And to me, these are things that honestly are kind of, I call it settled science. I mean, so I think when we're looking at policy and procedure, and to Maureen's point, you have to get out of your office to go look at what's really happening. But then you have to kind of marry up what the studies are showing, the evidence, to what is actually clinical practice. And that's where the magic has to happen. And that's called implementation science. That's where the rubber meets the road, for that old analogy, is that we have to make sure that if the policy is being written with more current evidence, that may change practice. And no offense, I think all of us on this that are listening to this podcast love change, right? No, we don't, because we have change as our middle name with healthcare. And I think that's where some of the challenge comes in, is that we need to not only do the look back, but we also have to start making sure we're implementing that. And that, I think, is where that whole process comes in.
Yeah, that you bring up a really good point about that. You have to go out of your office to get the right information, and that's kind of internal to the hospital, to go to the OR, go to the space where the work's happening, but then also go out of your office to the industry piece. And it's a great opportunity to sit. I mean, especially AMI committees. That's one. Go and sit on an AMI committee, because if you're participating in a committee, even if you're there to learn, and then you're going to have kind of an inside track to say, and we did this when TIR 109 came out about transport. And I knew with my organization, all right, there's these 3 policies that we're going to review because of new, and it wasn't even a standard yet. But we knew that this was coming down the pike. So we were prepared for it, instead of, 2-3 years down the road, your surveyor's asking about it. And now you're kind of caught on your heels because we haven't gone out of the office and seen kind of the industry impact. And I think this even applies with some of this very specific risks happening in the OR. So I think about percutaneous procedures. That's one that's really top of mind right now. And what are we using for ultrasound? How are those ultrasounds being reprocessed if they're coming in contact with non-intact skin for a percutaneous procedure? And that's one, as you said, Peter, that's one where we have to pay attention to what the standard is, and then also what the reality is. The reality of, hey, this is non-intact skin. There is evidence of breaks in sheaths, breaks in covers, breaks in, dressings. And is that a risk point for our patient before they even hit the OR? during line placement.
You bring up a really, to me, this is probably one of the most under-recognized risks that we have in hospitals, because ultrasound procedures are so, what's the word I want to look at? It's not invasive, but it means pervasive across the entire, there's
everywhere.
Exactly. What is it? 240 different ultrasound procedures, Maureen?
140. Yeah, 140.
There's tons of them. But what makes my head explode is when I go in and I see ultrasound probes sitting on the cart. They haven't been cleaned, and there's gouge marks in the transducers, which tells me that the aim of the clinician when they were coming in with that catheter was not very good. And so this, to your point, Garrett, is so important, is about making sure that we're reprocessing these transducers according to the manufacturer's written instructions. There is, I won't say it, this is kind of a hot issue for ARN and APIC because we disagree on the level of high-level disinfection for probes, particularly when they come into contact with non-intact skin or they're going to be going invasively. So I think this is where you really have to kind of go back to, Lindsey, you asked the question, what does the evidence show? And, what is the purpose of a guideline if it's not following things like Spalding classification?
Yeah, and also the, Joint Commission Perspectives that was published in 2019, it kind of lays out, if you're going to write a policy or procedure, the hierarchical way that you start, which is FDA, OSHA, Department of Public Health, the federal regulations are where you first start. Then the next tier down is CMS. And then the next tier down is the manufacturers' IFUs. And the next tier down is organizations that write standards, evidence-based guidelines like ARN or CDC. They're below. AMI is, also in that category, but they're below also. It's FDA, CMS, manufacturer. It might be actually, I got to look at it again, but it might be standards and then a manufacturer. Down at the very last one is consensus papers from organizations. Now, I know, being in Boston, that the reason the Sunshine Act got put into place is because they uncovered that consensus papers in cardiology and psychiatry were being written by pharmaceutical firms, and they were paying the doctors to put their names on these papers. And not that that's happening with some of the guidelines that we're following, but they're down at the lower tier that you look at a consensus guideline or practice guideline from an organization, and you are just ignoring what FDA or CMS or AMI is saying. I don't get that. Spalding says non-intact skin. So to me, and even I looked it up on ChatGPT and Grok and all of them, non-intact skin, percutaneous means you broke the skin. Now, I think where the confusion is, and again, it's because they're not going out looking at the procedures like what Peter and I do. When you watch a central line or dialysis line insertion, they'll often have the probe, say it was low-level disinfectant, but they got a sterile sheath and sterile gel, if you're lucky, on top of the area. And it's trying to guide the placement, down into that vessel, vascular system. The problem is, if they can't get it in, they start moving the probe directly on top of the insertion site. Now you get the clinician pushing it in and out, and the probe cover, the sheath, is hitting the hub and possibly the needle, and they break. There's blood very often in these procedures that you'll see. So now it becomes non-intact skin. It might have been intact skin over here, off of like an inch or so away from the insertion site, but now you're on top of it. So now we're saying, okay, radiologist or anesthesiologist or ICU, physician, you saw the blood, you saw you possibly broke the sheath, you're on top of the insertion site, it's now non-intact skin, so that has to go get high-level disinfection. Where do I bring it? Do we have one of the devices around? Do I send it back to central processing? So that's why sometimes we just standardize things. They're going to do it the same way for everybody, so no patient has a risk of having an infection. There, when I would do CLABSIs, I had primary bacteremias and secondary bacteremias. And then we had the CLABSIs and we'd be like, oh yeah, it was the central line that caused it. Do we really know that? Have we looked to see if they did have ultrasound procedures done with that line placement, and especially in the emergency room under those kinds of conditions? So there's just a lot of assumptions by people that are not going out and actually looking. And if they can't do that because some of them maybe are retired and they're writing these practice guidelines, or maybe they don't work in an acute adult setting, they work in pediatrics where it's really different. You've got to go out and look, or at least go watch on YouTube. That's how I got myself all up in arms after I saw those YouTube videos. I was, honest to God, I was shocked of the technique, lack of technique. And that's how I got on board with all of this, saying it should be high-level disinfection. And now there's, human papillomavirus is just on the edge of LLD versus, HLD. And that's why, obviously, you want transvaginals or even transrectals to be high-level disinfected, preferably even sterile. But that's some of the things that we get concerned about. Organisms are getting more resistant. And so, I don't know, can they outdo the, low-level disinfection and beyond that probe? We were in one anesthesia workroom. There's a cart there. Now, we look at the probes. They got gouges in them, and they have gel all over them, meaning that it had already been used on a patient, and the gel was still sitting there from the previous patient. We looked around to see if we could see any disinfection devices, any wipes, disinfectant wipes. There were none. So we asked them, how do you clean this? And the answer was, well, we put a sheath on it. And then we said, and we use sterile gel. The problem is we found unsterile gel packets in the room, as well as sterile gel.
They were co-mingled.
They were mingled together. One's blue and one's white. So we wouldn't have known that until we got them to unlock the anesthesia room. They didn't want us to go in there. So
it's always the anesthesia
room. We're going
room.
into the anesthesia room. Or, down in the emergency room, you might find it locked somewhere. I found a transvaginal probe cart locked in a room. And when we opened it up, and this was a setting, I wasn't with Peter with this one. And I said, how does this get processed? They all looked around and they're like, well, I don't think we use it. And then someone said, oh, no, yeah, the gynecologist, she does use that. And there was nothing, no system to be able to really high-level disinfect that. You only find that out by getting out of your office and touring and going and do your rounds, which I did every day. When I got to work, I would go up to the ICU. And then I'd check in with the microlab. That's the other team approach, is to get your microlab very involved with what you're doing. Because a lot of times the OR would call me and they'd say, hey, Maureen, we've got a rep that just walked in with his leather carry bag, and he's in room 3. I said, I'll be right up. And I had Rodak plates. So I'd get up there in the OR. I said, excuse me, I hear that there is a leather bag in this room, and I need to culture it. You should have seen their faces. So I'd go in and do a Rodak plate, show them all the organisms that were on them. Now it's like you have to have something that you can wash, or you can put into a plastic bag to take it into the room. So I was very, very much into, I did their lab coats. I did, the cloth skull caps. I did the back of their necks. Oh my God, did that open their eyes to what's all over the sweat, the dandruff, and the pimples on the back of their necks, and how that's drilling and reaming and sawing, and just dropping this stuff potentially into incisions, and they really were just on board with IP. I had no problems at all in recommendations to get things put in place because they saw that I was very, very active at a clinical level, not just sitting in an office collecting data and going to a committee and reporting on the data, the numbers. So I just wish that we had gotten, the first, when NHSM was designed, the intent from CDC back then was to have data analysts do that system, collect that data. Not IPs, but the market had crashed in 2008. And so this is when we were starting to implement it. And there's just no money in the budgets. Everybody was hurting. So it was kind of dumped on IPs to do this level of surveillance. One thing to collect data, which I always did my entire career from the time I started. But to upload surgical files and to do all the other stuff at the orthopedic hospital, I refused to do it. And they got an administrative assistant who was able to handle the entire NHSN program. I still went out and did the case finding, met with the ID doctor twice a week, went over the cases, wrote the cases up for the committee, But all of that other administrative stuff and running reports for the committee and uploading surgical files was done by an administrative assistant. We've got to get the IP back out to the bedside and in the OR a couple of days a week. Into radio, that's why those traces, they'll work really well for something like that. So that's
the other thing that, apart from transducers, if I can go from gross to grosser for just a moment.
You're with the right audience.
I was going to say,
yeah.
It's like I feel like we need to have like a caption at the bottom of this, gross alert, okay? But my other thing that I have a huge concern about in the perioperative environment, interventional radiology, cath labs, is the X-ray aprons.
Oh, yeah, what aprons.
Mm-hmm.
They're gross.
Mm-hmm.
And a lot of
who's cleaning them?
Yeah. No one wants to clean them.
Yeah.
So Maureen and I actually put in a proposal to speak on this at ARN this year. Yet to be determined if they're going to accept. But I think, we're speaking to infection preventionists today. I also want to talk to my colleagues in the operating room. Go out there and look at everybody's. Don't accept the fact that Dr. X or Dr. Y hides his lead in his collar shield in his locker. Get the plates out in culture. Because the thing that separates us from the wound is a very thin layer of polypropylene that has the potential to leak or break through. And so we don't look at lead as a potential source, but we should. And I think that's really important. And the other gross alert that I'm going to talk about is fluid on the floor. And that happens in SPD, L&D, ORs, cath labs, you name it. And then we're tracking it all over the place. We're rolling wheels through it, and it's going everywhere. We need to make sure we're using absorbent materials, not towels, not blankets, to make sure we're cleaning this up, because this is what's going all over the hospital.
Now, what I would do, if I was an IP still, I would go and take glow germ, push and glow by fluorescent powder, and sprinkle it all over that pile of blood. And then as they bring the stretcher of the bed in, track it with my little fluorescent light and see as it goes to the PACU, and then it goes out to the nursing unit. And the other study I've talked about is collecting sheets after they do these procedures and putting the fluorescent gel down into them and actually squirting it and seeing how many, say you collect 100, what percentage of those had a break. I either did cultures or I would do the fluorescent gel, and a lot of work that I did just so you can illustrate it, and make it alive so that this is what the bugs look like, or this is the potential for cross-contamination, and why we recommend what we recommend for different procedures. So just putting that out there.
The sheaths on these ultrasound probes are no different than surgical gloves or condoms. And we test surgical gloves with a water leak test, to Maureen's point. It's not rocket science to do this. You simply take a liter of saline and fill the sheath. And if it leaks, Houston, we have a problem.
Yeah. Well, and the kind of vision that you guys that you both have painted is an IP that has what I would call, maybe instead of active participation in their OR and in their hospital, but more of a stewardship role where they're actively engaged. They're, I don't want to say pushing the envelope, because nothing that you've described is outside of our purview or our kind of right to do as IPs. We're empowered to do those things. I think some of it's the courage to go in and say, hey, this is what I'm actually seeing in my facility, in my hospital, and nobody's going to write a standard for your specific hospital. But that doesn't negate your obligation to go in and say, this is what I'm seeing in real time in practice. And I think that's a shift, but a very, very important one to say, hey, IP, you're responsible. You are responsible for keeping patients safe while you're here.
Garrett, I mentioned at the very beginning, the IP is not there to be another OR nurse.
Mm-hmm.
The IP is there to be a trained observer. And that's what Maureen and I have been talking about this entire time. Is go out there and observe. Go probe. That's what a difference between good and great observers are. They don't take the status quo. They ask the why.
I love that. And as we round out this episode, and it's been phenomenal. As a host of this, I'm always excited for those episodes where like, I want to go back and listen to this because there's a ton of great information here. Lindsey, I see you nodding your head. I'm sure you're feeling the same way.
I have learned personally a lot, not just today, but in the course of the season to take back to my OR. And I hope other OR nurses out there have listened as well, because like I said, I can't be the only OR nurse out there who has not seen or worked with infection preventionists from the hospital. And it's giving me great ideas about how we need to just work on that collaboration. Just start with an introduction of who your hospital IPs are, and then go from there.
A couple of years ago, Peter and I coined the term surgical stewardship. We have antimicrobial stewardship. We have diagnostic stewardship. We really should have a surgical stewardship program that's under patient safety council or quality, depending on your hierarchy in your hospital organization. And that's a committee that would then have task forces. I kind of had a similar one when I was at New England Baptist, and one group of us worked on MRSA screening protocol, another one worked on the post-op standardization protocol, and we worked with EVS. We had different subgroups that reported to that group, and then that group, I would give a report to the Infection Prevention Committee. So we didn't bog down the Infection Prevention Committee because they have other HIIs they're dealing with. So that's something we put out there. And we even, bought the domain and everything. We're like, really want to kind of push that concept of, as you said, Lindsey, teamwork. It's just can't be on the head of the OR leader or the IP. You need surgeons, anesthesia on board, even perfusionists, EVS facilities, the air quality management program you're supposed to have. I mean, there's a lot that goes in having a really good, robust SSI prevention program. So that might be something for people to consider, surgical stewardship. Yeah.
I love that. And what a good kind of go and do for the audience listening, whether you're on the IP side of the audience or the OR side of the audience, kind of parse through this episode, take it back to your teams, and then say, how can I develop this collaboration, break down the barriers, break down the silos to really get to this? And Maureen, tell us the term again, surgical stewardship.
Yeah. Similar to antimicrobial diagnostic. That's the term we're using now. I wish, Joint Commission put out in the medication management module in 2017 that you were to have an antimicrobial stewardship. I wish they would put it out that you're to have a surgical stewardship. They do have a really good 2015 National Patient Safety 070502, I think I forget the numbers. That was a very thick document on SSI prevention, but nobody ever talks about it. You don't really hear. So I think that's what we need, something that really pushes stewardship, similar to the other two that are now common in hospitals.
I agree 100%. And Maureen and Peter and Lindsey as well, I want to thank you all for joining us and sharing your expertise and perspectives on the podcast today. Always great to have a conversation with you and share that education out with the audience, where I'm sure people will have follow-up questions and wants more information. Where can they reach out to you, Maureen and Peter?
We are both, our website is surgicalinfectionconsultants.com. Our CVs are there, and we have some podcasts and educational materials, a couple of ebooks that we have. So that's the best way, or my email is maureen.spencer@gmail.
You can also reach out to us through our LinkedIn page, surgical infection prevention
group. Yes, please join. That's where we're posting.
It's a great group. Yeah. I'll say from experience.
Yeah.
It's
and we're about to kick off a surgical procedure series on how to prevent infections. I'll be taking the actual procedure. Maureen will come at it from an IP perspective. We've got over 2,500 members across the globe. It's free to join. We don't allow any, infomercials to be placed. It's all evidence-based practice. and it's free to join. So just ask to join, and we look forward to approving you.
Yeah, absolutely. And yeah, cannot endorse that enough. Go out and check out great education, great resources out there. So thank you, Maureen and Peter, and thanks, Lindsey, for joining us. And thank you to our audience. I can't think of a better way to wrap up this season, especially one on collaboration between infection prevention and the operating room, than by listening and learning from Maureen and Peter. One of the biggest challenges, I think, is having a systematized and really great methodology to looking at the patient record, looking at the environment of care, looking at all of the documentation after the case when you're reviewing an SSI. And they had so many tools and insights that were shared with us today, and probably 20 other podcast episodes worth of information. So 2 of those guests that you wish you could just, run the podcast for like a whole day and just ask them all the questions you have. But thank you to the audience for joining us all season long. If you're in the OR listening to this, share it with your IP buddy. If you're in infection preventionist, share this with your friends in the OR. We want to thank our guests for making this such a phenomenal season, as well as our co-hosts throughout this special combined season. And we want to thank everybody for making this such a great season. Remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.